All right, so we finally get started.
Okay.
What?
So Dr. Montero. Oh Lord Jesus. Audio off here. Okay. Dr. Montero, right? He is our TGH ASP, one of the best clinicians I know. He'll be talking to you today about antibacterials, antibiotics, correct?
Correct.
Go for it.
Like I said earlier, this is going to be early on. It's going to be very common review stuff. At the end, it's sort of stuff that I want our fellows to really pay attention to as far as resistance, because that's something that's with increasing resistance. We're going to have increasing choices that we're going to have to make as far as appropriate antibiotics. Right now, a lot of these choices are being made for you because of, for example, my team will contact the lab when they see resistance occurring. But when you go out in practice, that may or may not be happening. And so you will need to learn how to handle some of these more advanced, gram-negative, gram-positive resistant agents. So we're going to discuss different classes of antibiotics commonly administered in hospital setting. You know, how many people, what percentage of hospitalized patients get at least one dose of antibiotic?
100.
Not 100%.
85.
So it's anywhere between, if you look at data, it's anywhere, in our data at least, anywhere between 55% to almost 70%. So, and a lot of that may be single dose surgical prophylaxis or whatnot, but antibiotics are tasted by a lot of our patients coming in. And it's a group of people who never get tasted. You get mom delivering a baby and she's not, it's GBS positive, she's not going to get an antibiotic, for example. So that includes all those. So we'll review the antibiotic spectrum. We'll list the common adverse reactions, and then I'm able to discuss antifungals and antivirals. I can barely do antibiotics in one lecture. So we'll just deal with this. This is what we do as ID. We try to predict our pathogens by doing our history. When they get our history, we try to find the location of infection, the risk factor for the patient for an infection, or what type of infection we're dealing with. We do a travel history because it does affect potentially what we can or cannot perceive as a risk factor for an infection. And then we have other things like time of the year, geography, and other aspects of our history to try to help us predict what pathogen. You'll see the slide from me all the time. This is what we kind of do all the time. All of us do it. How broad the antibiotics is depends, is proportional to the risk of the complication of the patient, and inversely proportional to what the heck you think is the diagnosis. So what do we affect here as ID clinicians, as clinicians in general? The denominator. Hopefully, we increase that with our history, with more data that comes in over time, and as a result, you will de-escalate and decrease your broad spectrum of antibiotics. Sometimes we do that pretty early in our evaluations. Sometimes, sepsis with unknown etiology, even after decent history, you have to go broad and then de-escalate. So this is what we do clinically. The risk of complications is kind of fixed. I mean, if you're a 20-year-old otherwise healthy, it's different than if you're a 60-year-old post-transplant, a liver transplant with recurrent cirrhosis. That's a whole different risk profile and potential pathogens that you're dealing with. I always have a slide on allergies as well, because I think this is one of the areas of ID in medicine in general that we do a very poor job of. Talk about beta-lactams. Beta-lactams are commonly used. 10% of patients report some kind of beta-lactam allergy. It's kind of ridiculous if you look at it. Some actually may have had a reaction, may have not been an IgE-mediated reaction. But out of those, about 85% probably do not have an IgE-mediated reaction. They may have had a delayed reaction, they might have had a side effect that they claim to be an allergy, but true IgE-mediated allergies, which are the ones that we worry about, are very infrequent. So out of that 10% reported, that's 2% actually truly have an IgE-mediated reaction to penicillin, for example, or any other stuff, beta-lactam, that we worry about. Most allergies listed in medical record do not have a documented reaction as well. Who does the allergy assessment? We should be doing it, but it's not us. It's the intake nurse, whether that intake nurse being in the ED or as they get admitted to the hospital. That's who really does the allergy assessment. And they usually have that with a long list of laundry list of other things to do, including taking care of an acute patient at the hospital. So as a result, this kind of gets ignored. And that's why we have such poor allergy assessments. Sometimes they come from another facility. If the patient's altered, they come from an ALF, we take whatever's on the ALF form as they transfer over. So there's a lot of work to be done here. Every hospital has this problem. And we just have to try to make it better with time. And it does affect how we take care of patients. As we all know, we also know our normal flora, because the same normal flora can be our pathogens if there's altered mucosa, altered anatomy and whatnot. We know that our skin is strep. We know that our intestinal pathogens are mostly gram-negative and anaerobes down further down in the colon. Our mouth is anaerobic and streptococcus, et cetera, et cetera. I have one slide on MIC. MIC is something that we all know stands for minimum inhibitory concentration. Problem I still hear every now and then, even from hospice, the lower the number, the better, isn't it? Yes and no. Really, you can have problem. It depends on the concentration of the drug into tissue. For example, Septra, sulfamethoxyl, you'll never see something less than an 8 or 16 in there, and that's acceptable because it depends on the concentration of that drug that gets into it. So an MIC of 1 for Cipro to E. coli is not better or worse than 2 or ceftriaxone. It doesn't imply that Cipro is twice as effective. In fact, probably the opposite, frankly. It does indicate the concentrations achieved by that drug by recommended doses of other drugs are likely to be active against that agent. So you don't have to memorize a ton of these. There's certain ones you should know. Staph aureus and Vanco, you should know. Some of the ones that have changed recently. So some of the Enterobacteriaceae and quinolones have changed recently. You should know the subjective number. Pseudomonas, for example, you should probably know where the breakpoints really are for cefepime and Tesa. Those are the ones you should know because they're the ones that tend to be ones that you worry about having to alter your drug therapy. If Vanco MSC ends up being too Staph aureus, it might be reported as sensitive, but technically it's very hard to achieve a adequate dose of vancomycin that's not toxic to the patient for a very serious Staph aureus infection, and therefore we use alternative agents. We've all seen this, a slide similar to this at least, describing antibiotic mechanisms of action. And we have it's basically war. We're having a war against the microbe, all right? This is our armamentarium against the microbe. We have wall-busting agents, cell wall-busting agents, whether they be beta-lactams or vancomycin or others in there. We have agents that handle the spinning of their genetic material, the DNA gyrase. We have other things that handle protein synthesis, whether that be the 50S subunit or the 30S subunit of the ribosome, or other areas such as transfer RNA or RNA polymerase targets. So we have an armamentarium against a lot of microbes that we targeted through much of the cell cycle or the boundary of the cell. As a result, the cell fights back and forms defenses. This is an example of gram-negative defenses against some of these mechanisms we have tried to attack. For example, starting at the top of it, you have beta-lactamases. So our drugs, our beta-lactamases get into a periparathymic space, but they have countermeasures called beta-lactamases that sort of knock off those in that periplasmic space and make those inactive. You have going to 1 o'clock around, you have overexpression of efflux pumps. So all of a sudden you have, normally you might have 1 or 2 pumps pumping out some antibiotics to try to form defenses. All of a sudden this new bacteria, this new gram-negative has multiplied that by tenfold, and therefore pumping out the antibiotic. You have antibiotic modifying agents. You have different targets and mutations that affect the cell cycle that circumvent the armamentarium that we are trying to attack. Or you just bypass the targets altogether. Or you lose porins. Porins that normally would allow antibiotics to come in or normal passageway, you block those off. So there's tons of mechanisms that antibiotics have, antibacterial agents, organisms have developed over time to circumvent the armamentarium that we have. It's all about war against the microbes, so to speak. So let's go over some of the drugs in cells. Beta-lactams, they inhibit the transpeptidases of penicillin-binding proteins responsible for cell wall synthesis. It is time-dependent bactericidal activity in most pathogens. So there's time over the MIC, time over that minimum inhibitory concentration. It's important for beta-lactams. That's why most, not all, most beta-lactams are dosed very frequently. They have to be to maintain that. All right. Their spectrum of activity depends on lots of things. The affinity for the target for that penicillin-binding protein. Are they able to penetrate through the pores of the gram-negative cell wall, or are they not able to? And how stable are they to those beta-lactamases, those countermeasures that the gram-negative bacteria have? And in general, cephalosporins are intermediate but are better able to than penicillins, and carbapenems are actually better than cephalosporins to be able to avoid or be stable in the face of these beta-lactamase degradation. What do beta-lactamases do in general to help you as far as targeting? For example, what happens if you have ampicillin and you put sulbactam to it? Basically, sulbactam adds what to it? Adds a little bit of staph force, a lot of anaerobic coverage, especially bacteroides, and a significant amount of gram-negative coverage as well. What does it do to piperacillin when you have tazobactam, another beta-lactamase? It adds a teeny bit of staph force coverage, a significant amount of gram-negative coverage, and bacteroides coverage. It does nothing to Pseudomonas coverage. It doesn't really affect that because that's not the mechanism of resistance to Pseudomonas that occurs. We've all learned this in medical school. The cephalosporin class, which I think is kind of crazy and kooky, to be honest with you. We've all learned early on that first generation cephalosporins, great staph, and as you go up to the generations, the staph coverage generally goes down, except for like the fourth and fifth generation. You have a little bit of staph coverage in cephalosporin, and cephalosporin, the quote-unquote fifth generation, has a lot of staph coverage. All right, and we all learned early on the first generation cephalosporins have pretty poor gram-negative coverage in general. It has some, and as you increase in the generations, they generally have increasing gram-negative coverage. And that's certainly true as generality it goes. The fifth generation cephalosporin, quote unquote, I don't know if they still call it fifth generation. At one point it was coined that. I call it ceftriaxone plus vanco. I call it ceftriaxone plus. It's ceftaroline. It is active against gram-positive. That's Pseudomonas, so that's why I say ceftriaxone. And it has MRSA coverage. FDA label, what's it indicated for? Things that we never use it for. Community-acquired pneumonia and skin and soft tissue infections. We use it for its MRSA coverage when we need it, when our vancomycin MSC is 2, or we have persistence and whatnot. That's why we have a TGH, but it's restricted because people will use it for those indications. So we have a lot of better agents, in my opinion, for community-acquired pneumonia and for skin and soft tissue. But that's what drugs get. That's how drugs make it to market. They do studies against us to get the indication for this. But in this study, it's a good example of one that's used in some other fashion. So where are these, where do we place these generations of cephalosporin therapy? First generation, great for either skin and soft tissue or surgical prophylaxis. There's really a lot of use of cefazolin in that setting. The lost generation, I call it, the second generation, really, it used to be used a lot back in my day. 25 years ago, cefuroxime was my go-to COPD flare type of worry. You could use it for cat back in the day. Cefuroxime, you can barely find it anymore. Used much in the hospital setting. But cefoxitin or cefotetan, we still use it quite a bit for PID. But it's a lost generation. It's being used less and less with time. Our third generation is our workhorse generation for the hospitalists, I call it. It's great for urine, for CAP, meningitis, and whatnot. And then cefepime, our fourth generation agent, is our workhorse for sepsis and nosocomial pneumonia, for example. And we've already talked about our ceftaroline, our fifth generation agent. Carbapenems, we got 4 of them. I put 3 up top, 1 at the bottom here. Imipenem, meropenem, doripenem, and ertapenem. TGH used to be a doripenem hospital until like about 10 years ago. We switched over. So there's a few of them out there. There's a very few out there of them out there. But I separated them out because we think these are two different agents. The top three agents tend to be broad spectrum, broad gram-negative, broad anaerobic coverage. Virtually everything is covered. Well, not anymore. We all know there's agents that aren't covered by these. You got a lot of carbapenems. You got cephalosporins that's intrinsically resistant to this, et cetera, et cetera. In general, it had broad coverage and okay enterococcal coverage. And I think this is something I think people overestimate their enterococcal activity. So yes, they do have some. Out of those top three agents, which one has the best enterococcal activity? I'd say imipenem actually does. So we think of carbapenems having great enterococcal coverage as well, but they don't. They have okay, but they're excellent gram-negative coverage. They have very broad negative coverage. And their anaerobes are very outstanding as far as their coverage as well. We tend to reserve these for very serious infections, especially people who've already been exposed to a lot of antimicrobials and we worry about resistance. We use them up front occasionally when we're worried about we have to have excellent gram-negative coverage in someone with sepsis and excellent anaerobic coverage. But it tends to be more reserved with, early on, not always. Ertapenem's its own little species, I might call it. It's a once-a-dayer. And when it came out to market, Merck had this. When it came out to market, they didn't know where to put it. And it took years to figure out where to put it. Now it's a great OPAT drug. It has very good gram-negative coverage, but it doesn't have that pseudomonal coverage that the others carbapenems do, and it doesn't have the Acinetobacter coverage as well. But it does have otherwise great gram-negative coverage and anaerobic coverage. And all these agents, the where we put these generally, especially ertapenem, is our ESBL producers. This is where we actually place them in therapy. If you have an ESBL, you start to think, okay, if they're not susceptible to a non-beta-lactam like Septra or Cipro, you're thinking ertapenem or another carbapenem. That is your drug of choice at that point in time. In general, beta-lactam adverse reactions, you got a lot of beta-lactam, so you got a lot of reactions up there, all right? Reality is allergies are not that uncommon. GI effects can be sort of common depending on the agent you're worried about. Ceftriaxone, you're always worried about pseudobiliary lithiasis, a little bit of sludging of the gallbladder. Hepatic, which beta-lactam tends to have develop high LFTs if you continue therapy. You can get a little bit of ceftriaxone. Oxacillin is what I'm thinking of as well. Those are agents that you think about. If you have someone on oxacillin for, let's say, endocarditis, and then 2 weeks later LFTs go up, it's oxacillin. You're going to have to use something different. CNS seizures tend to decrease the seizure threshold with most beta-lactams, especially if you use them at high doses. The category of drugs that tend to be the highest reduction in seizure threshold would be the carbapenem class, with imipenem probably the champion there. But the others like doripenem and meropenem do have an ability to decrease the seizure threshold as well. And don't mention carbapenems and seizure without mentioning the valproic acid interaction with carbapenems. I didn't know this until 10, 15 years ago, but it is huge. You give a carbapenem to someone who's on valproic acid, you reduce the amount of valproic acid effectively in that patient by more than 85%. So if they're using it for mood stabilization, that's one thing. But if they're using valproic acid for seizures, and you're already getting something that's going to decrease your seizure threshold and remove the valproic acid, you can see the problem that exists here. And that's why this pop-up comes up many times when you try to order it. Monobactam is its own little container, so to speak. And basically has its only single drug, S3NM, in it. And the only hole we use S3NM for typically, and always now, typically would be for our beta-lactam allergic patient who needs gram-negative coverage. And you don't want to use a quinolone or whatnot. So it's got excellent gram-negative coverage, including Pseudomonas. But it doesn't have great Acinetobacter, Steno, or Volcodarea coverage. It basically exclusive gram-negative, 0 gram-positive, 0 anaerobe. Only one other agent's like that. That's a beta-lactam. That's ceftazidime, which we don't use much anymore. Different agents now. Quinolones. of action inhibits the DNA gyrase. Who thought unwinding and winding would be such a big deal? But this is how we attack this the bacteria in this manner. These are synthetic, broad spectrum, and they generally cover gram-positives and gram-negatives and quote unquote atypical organisms. The atypical organisms are like the chlamydias of the world, the mycoplasmas of the world, those atypical pneumonias that we think about. Newer agents like moxifloxacin, which is not new anymore, has increased anaerobic coverage and a little bit of mycobacterial coverage. Actually, most of the quinolones have a little bit of mycobacterial coverage. You'll see them used occasionally for TB, for example, with some NTMs, depending on which species you're dealing with. Unlike the beta-lactams, these are concentration-dependent bactericidal activity. So the higher the concentration, the better you're off. Not the time over the MSC as important. It's mostly concentration-dependent. They're very well tolerated. These were abused and still being abused, but we were really abused about 5 to 10 years ago by everybody. It's like statins are abused now. Well, this is statins of antimicrobials, in my opinion. All right, everybody was taking them. Why? Because they're well tolerated, oral. Any hospitals could give it. Any international medicine could give this. The problem is, over the years, it's gotten black box warning after black box warning, and things being found against because it's been used so much. There to be C. difference inducers, but these are the adverse reactions that sort of over the last 5 or 7 years have seen a reduction in the usage, not because it's necessarily resistance, which there is a little bit more of that, but because these adverse reactions are being more and more recognized, where that be just GI discomforts, neuropsychiatric issues, sleep disturbances. You can get a good rash with quinolones. They can give you usually a delayed reaction, but it still gives you a drug allergy. They can be photosensitizing. It's one of those agents when if I use it for a period of time, I will tell our patients about sunscreen. These are more things that we started to think about. QT prolongations is associated with quinolones. It's also associated with other agents that we use. Liver failure is less common, but it has been reported. And then nephropathy, nephritis is rare, but has been reported. The bigger things that have been reported that are more common are these arthropathies, the Achilles tendonitis, and then the potential effects. And I say the potential effects on aneurysms and dissections. I am not sure how much of this is real or how much of this is seen, but there have been an association with aortic aneurysms and dissections. I'm not sure that the causal is there, but the association has been. And so you tend to think twice in someone who has an aortic aneurysm before using a quinolone. It's sort of risk benefit and maybe duration benefit as well. How long you want to do that? That's it. Macrolides. Not going to talk much about macrolides in one slide. It's bacteriostatic. Work on one of the subunits to prevent bacterial protein synthesis. We have 3 flavors: erythromycin, which still is a flavor, erythromycin and azithromycin. All but clarithromycin have an IV and PO version, and they're used more for respiratory infections, chlamydia, atypical infections like Lyme disease as well. And we use it in our HIV population for MAC treatment and or prophylaxis. We used to do a lot more prophylaxis than we did in the past because we used to have a lot more sicker patients, I think, in our AIDS that would not take our medications than we did in the past. But these agents are very effective. They work. Some of them tend to work longer than our therapies. For example, azithromycin, you get 3 or 5 day courses with the effects of it being a bit longer than that. Aminoglycosides inhibit the 30S ribosomal subunit. They tend to really well after our aerobic gram-negative rods. Pseudomonas activity, tobramycin is much better than gentamicin. In fact, gentamicin, we actually reported in our antibiogram against gram-negatives because we really want to try to separate Tobra and Gent. As Gent being more of gram-positive, it does have gram-negative activity, but it's an synergistic issue. Where Tobra is really more of a gram-negative, a little bit better pseudomonal activity over Gent. Amikacins requires a little bit more work to get resistance to it, so it's used in our subsequent spectrum, so to speak, of aminoglycosides to hit our more resistant gram-negative rods. We use them synergistically with cell-wall active agents too for gram-positive organisms, although that is fallen out of favor in general. For example, our endocarditis, we used to do a lot of gentamicin addition for synergy. And with certain studies, for example, when Dr. Meissen came on board, we compared it sometimes in endocarditis with this anti-cephalococcal agent and gent. And the toxicity of the gent came out a little bit more than we would like to see, and therefore it's being used less and less. We still use it occasionally, for example, in an enterococcal synergy, although that's being used less and less as ceftriaxone as the second agent for enterococcal activity. For example, AMP and ceftriaxone instead of AMP and gent has been seen more and more over time. Aminoglycosides do have post-antibiotic effects, and they're also concentration dependent, and therefore you have different dosing strategies. You have the old traditional dosing strategy, which is used less and less, and it's used only mostly in the synergistic role of these antimicrobials. You'll see that dosing regimen used with synergy. Whereas we've all heard Kristen recently lecture about how dosing you can give once a day dosing for aminoglycosides. And that takes advantage of that post-antibiotic effect and concentration-dependent killing to actually provide a significant large dose of drug and more effectively with less toxicity. I always tell my medical students, what is aminoglycoside? Aminoglycosides are horrible drugs except for two locations of the body, the urine and the blood. They're excellent there. And they can nuke the urine, most UTIs, and they're great to clear the bloodstream. To try to get it into soft tissues and bone, and even though we've used it in lung before, I still think it's pretty crappy of drugs to get into that. They don't do that well there. They do very well in the urine and very well in the bloodstream.
If you have someone with like really resistant UTIs and they are sensitive to tobramycin, would you say that monotherapy with Tobra would be acceptable?
I would say if it's a simple UTI, you could consider that. If it's a pyelo, or a complex UTI, I would be careful. So yes, if it's a simple cystitis, now that seems like overkill using an aminoglycoside for cystitis. Yes, it's fine. If it's true pyelo, remember that's also getting into tissue. You could probably use it. Try to use a different agent. Has it been done? Have I done it before? Yes, I've done it before. That's been maybe a couple times in my 25-year career. So it's not something that comes up commonly at all. There's usually other alternatives, although you see urine pathogens again, all kinds of resistance now that are basically untreatable. And so you start thinking in that fashion. You start thinking in fashion that it says resistance, but you get such high levels of aminoglycosides, you may even overcome that, even if it's reported as resistance, because you get that high levels of aminoglycosides in the urine, only if it's a simple infection. Adverse effects, we all know them. Basically, nephrotoxicity, generally not always reversible. Ototoxicity, unfortunately, usually irreversible. That includes your lack of hearing, or even worse, lack of balance, which can cause chronic nausea and instability. When you see these cases, it's pretty sad. You see them. You don't see them often because aminoglycosides in general are not used in long courses except for certain unusual circumstances. But it's something you guys have to pay attention to. It's not all looking at the creatinine. It's also understanding the other toxicities that exist. I've not seen much of the neuromuscular blockade that's been reported. Sort of like what you see with maybe steroids and critical illness, but I think I've seen one case of it. We just don't use aminoglycosides as much. Remember, aminoglycosides is one of those drugs you don't use in myasthenia gravis because they exacerbate a crisis as well. There's a lot of other agents in there as well, including quinolones. Vancomycin impairs cell wall synthesis. The spectrum is pretty much gram-positive in general. It has 0 gram-negative coverage, 0. And the only gram-positive of note it has coverages is really Clostridium. In the oral form, we use that, an example, to treat C. diff. But otherwise, it's pretty a strict gram-positive agent. It impairs cell wall synthesis. You had the D-alanine portion. Pharmacokinetics, again, Kristen's talked to you about this a few weeks ago. It's concentration independent. So it's time over AMIC, although the AUC over AMIC is really the better predictor of efficacy. We all know when we start vancomycin, we need to load the tank, give a loading dose. The old strategy was trough-based strategy. We kept the trough above 10. And for serious infection, you kept the trough around 15 to 20. Unfortunately, you're probably overdosing most of these patients and causing toxicity. Now there's much more emphasis, especially on staph MRSA infections. You go AUC over MSC, targeting some infections over 400, and for other infections maybe 500, depending on severity of infection. Many places now, actually all our places are having you being dosed by pharmacy, correct? Does that include the Moffitt and the VA as well? All right. Toxicities, understand toxicities. Nephrotoxicity has always been debatable. It's usually increased when there's another agent that's usually toxic as well to the kidneys. Although there's been well-documented examples of toxicities just with vancomycin alone. The question is, what came first, the chicken or the egg? Did the creatinine get worse and then the vancomycin level rose up, or the vancomycin level rose high enough to cause the kidneys to cause it to go up as well? It's always been associated with it, but how much of it is the cause versus possible cause and effect? I try not to use red man syndrome anymore, but we all know what it means. It's vancomycin infusion reaction is the technical term for it, okay? It's an infusion rate dependent reaction related to histamine release as the infusion occurs. I can give every lady in this room, I'll give you a squirt of vancomycin fast enough, all right? And it can scare the living bejesus out of you, all right? And that's what it does. When you see a patient having it, you go to ER, they get it too quickly, and they say, oh, I'm itching all over. You see it going, not with a pump, but they're going in with drips. So they probably overestimated the infusion time it's going in. It's tingling, erythema, flushing, face, upper torso, sometimes associated with a little bit of hypertension and tachycardia, a lot of histamine release. The key for this is how soon did it go away? Oh, as soon as they stopped it, I felt much better. It's like, well, you still have all that vancomycin in your body. It's an infusion-related reaction, so you're not allergic to the actual drug. You're allergic to the speed of the infusion. So you generally, the way you mitigate this is you slow the infusion down. Most infusions of vancomycin are over 1 hour. Now, if you have 1.5 grams to 2 grams, they usually give it even longer than that, like 2 hours. You might have to go 2 to 3 hours with sometimes Benadryl to try to reduce this. Even some individuals are so sensitive that even that causes a problem, and therefore we don't call it an allergy, we call it a significant vancomycin infusion reaction, and we have to use an alternative agent at some point if that occurs. I put a couple slides basically on site of penetration just to remind us that every antibiotic goes to every part of the body. Most drugs get indicated for pneumonia and skin and soft tissues. That's why you see pretty much most agents get crossed off there. But there's certain drugs that you need to know where they don't get into. For example, in the urine, clindamycin is a no-no. You never see clindamycin used there. Why? Because it doesn't get in there. And it does get in there a little bit, so you can consider using it in your VRE UTIs. First of all, make sure it's a VRE UTI, really true UTI, not asymptomatic bacteriuria, but it does have a little bit of activity in there. And your blood, clindamycin, also the poor, again, clindamycin is one of those drugs that poor urine, poor blood. It's the opposite of the aminoglycosides, so to speak. Remember that daptomycin doesn't get in the lungs because it gets inactivated by the surfactant. And your CNS infections, a lot of these agents have a hard time. Actually, most agents have a hard time getting in. That's why you see the ones that are active have a plus on them, because you need high doses to get in to be effective. You need high doses of cefepime. You need high doses of ceftriaxone. You need a higher dose of meropenem to get in there, et cetera, et cetera. So now this part of the lecture, we're going to look at some of the activity against some of the more resistant gram-positive agents. Whether we talk about cephalosporins or lipoglycopeptides or cyclic glycopeptides. There's others. Yeah, I was gonna look. The today's I hear it's not going to be made much longer. Well, no, for quinolone, we're all talking about delafloxacin. That does have some gram-positive activity. We won't talk about anymore. Same thing with the famulin. We're not going to talk about because no one uses it, and you guys won't get tested on this. And then sinucid, a vestige of the past. It stopped being made a couple years ago, and probably a good thing because people who got this drug felt pretty crappy when they got this drug, but it was needed at the time. This is a time when we didn't have agents for VRE, and we had no daptomycin, we had no nasal, so there was an agent called sinucid, quinopersin and dalbavancin that we used. So our glycopeptides, our telavancins, our dalbavancins, our ridavancins. These are the mechanism of action. Basically, these are vancomycin-like agents. Their mechanism of action and spectrum is such that it's like vancomycin. Telavancin may be probably the most potent out of the three, believe it or not. And so if you want to vancomycin on steroids, quote unquote, that's your telavancin agent. There's dosing differences. Telavancin is dosed daily. Dalbavancin is dosed weekly, or ridavancin is potentially once. And you might be done. It might last 2 weeks. These are appealing for outpatient treatment, but the cost of logistics currently limited in use. Over the last year, TGH has taken advantage of being able to discharge people on dalbavancin because it's a weekly agent, and we've actually taken advantage of the fact that if you give it a second week in a row, that second week lasts more than a week. It lasts about 3 or 4 more weeks. So essentially, with 2 doses, you get 4 or 5 weeks of therapy, and you've already had the 1 week in the hospital. You pretty much have your 6 weeks of therapy there if we can set it up. And so we've done that where we've given a dose as they get discharged, and we have them come back 1 week later to give them their second and final dose for their long course of therapy of 4 to 6 weeks of therapy in many cases. It's not easy though, because you have to these are patients that typically we choose to give to this because they're stuck in the hospitals. They're uninsured or uninsurable, and they may have social situations that may not prompt them to get to a nursing home or skilled facility like current or IV drug use. We have people who've had felonies on the books and no SNF will take them. So we've had to potentially do this as well. But the logistics are not that easy. Easy to think about getting it done. And the drug companies will tell you, oh, it's easy, just do this and that. The logistics are not that easy. That's why it's not being done a lot. Daptomycin, we all should know, binds the cell membrane in a calcium-dependent fashion, resulting in depolarization. So your potassium leaks out, and therefore your cell dies. It doesn't explode like we think of with beta-lactams. It just dies with the shell itself, so to speak. Has activity in staph and enterococcus, including VRE, although you use higher doses with enterococcal coverage or VRE coverage. Again, we talked about no activity in the lung. One thing you do need to know about is the CPK elevations and the myocytes that occur in about 2% of people. So it's not common. That's 1 out of every 50. You'll see it, but you won't see it often. But you should do weekly CPKs just to screen for it. And I forget the threshold that we start coming off, but you kind of see the gist of the rising CPK and figure out, okay, we're at 500 where we were at 250 last week. That's too high, too fast. We had to start thinking about switching the agent if that's the case. I've seen only 1 case of eosinophilic pneumonia, but there's been multiple reports of it. It's something you need to know. Be aware of. If you have someone who has a pneumonia, a quote unquote atypical pneumonia, and they haven't been on daptomycin for something else, you got to think, could this be eosinophilic pneumonia from the drug itself? Also, the linazolines of the world. I can't say the drugs class. They inhibit protein synthesis by preventing the formation of initiation complex of mRNA and methanol, tRNA, and the ribosome. So it prevents protein synthesis. It's activants, basically staph, strep, enterococcus as well. We also find, and now more recently found out, they've got pretty decent coverage and a lot of mycobacterial coverage and nocardia coverage as well. So you're seeing this agent being used more and more. One thing you need to know about this agent, excellent bioavailability. We're talking 95% plus. I think it's 98% plus, something like that. But the issues you do have to realize are the adverse effects as well. The serotonin syndrome that you can get, especially if you're on certain MAO inhibitors and things like that. SSRIs are probably overestimated. It can occur, but it's probably been overestimated. Thrombocytopenia is actually more common than you think if you use it more than 10 to 14 days. Optic neuropathy is something you want to avoid, and that's why we tend not to use these long term, although at times we're forced to. As well as peripheral neuropathy can be quite debilitating. I've seen one case of this as well. It's pretty debilitating. This is the relative cost. So this is something I got from someone else a year and a half ago. So this is cost of a year and a half ago, but it shows you the difference in cost. The dalbavancin isn't $6,000. It's actually for us it's $3,500, maybe $3,800. So it's not cheap. If you do that over 7 days, you break that over 7 days, it's a 7-day therapy. Or if you do it 2 doses, it's still expensive. But TGH has gotten to the point where it's more expensive to keep them in the hospital, unfunded, and when they have an issue. And that's why we've had the program set the way we have it. I do believe the VA is using dalbavancin. Is that correct? Yes. All right. I'm not sure how you guys got the cost for that. There's got to be some federal benefits that got put in there because it's a VA way, I guess. But you guys have to understand that when you get trained one way, when you go out into the community, it's a significant cost still. And I think it's not 6,000. I think it's 3,000 something, but still quite substantial. You look at vancomycin compared to all those other ones, it's still pretty cheap. Linezolid used to be expensive as all get out. And that's $5 a day for oral. And that's pretty darn cheap. It was quite expensive when it came out initially. Even the IV version is still a little bit expensive, but not nearly what it was way back in the day. So that's come down. It's amazing what happens when patents go out. Gram-negative agent.
Hey, Jose, this is Anthony Canella. You got a second? So
Yes.
regarding the VA and dalbavancin, so 2 things. Number one, it's part of the reason that we're doing it in some patients is because it's part of all the pool of money that goes to community care for antibiotics for OPAT. We take it out of there. And so it's not like we're getting a special price or anything. So that's how that's working.
You're subsidizing it.
In a way, yeah. And then, but we're actually, myself and Tiffany Warden, eventually some of the second-year fellows will be doing a QI project while they're on ASP to actually see the not only the cost benefit, but actually the morbidity benefit. Because we're seeing anecdotally a lot of improvement with regards to kidney function and other problems that usually occur while these patients are on OPAT, since they're on dalba. And the last thing I'm going to mention is that come January of 2024, dalbavancin will go generic, and thus it will be dirt cheap at that point compared to what it was before. So there is some a silver lining that's coming about the drug.
Actually, our experience at TGH has been actually surprisingly good as well. You understand what we use it in at TGH is IV drug use population where we can't get them into, we have to keep them in the hospital essentially. These are people that are disenfranchised socially, have lots of barriers, and we've actually done very well with these patients. We've had none really come back for their infection, and these are patients that typically leave AMA not for their therapy. We've actually been able to finish these people's therapy and not have them come back, which is surprising. We're going to have failures. We haven't really hit that yet, and I'm kind of shocked, frankly. We've had 13 or 14 patients we've done this with, and you think of that population, I would have thought 10 of them would have had problems. We've had one patient come back because of falls, not because of the drug itself or the infection itself. It's because falls in pain control. She came 2 or 3 times, right? Jacqueline.
Yeah, when it comes down, in fact, there are 3 studies right now in different countries in the European Union that have showed actual benefit to patients who have endovascular infection. So the real problem with dalbavancin is that it's highly albumin bound, about 94%. So that's the real problem with it. So if somebody is, has really poor nutrition, it's not the ideal drug. Of course, a lot of drugs are like that, but I agree with you. It is. I think it's going to be used more mainstream for things like endovascular infections and stuff like that. It's not using the old school vancomycin that we've been using for about 50 years. I'm sorry to interrupt your presentation.
No, that's great. That's Thank you very much. He did endocarditis for vertebral osteomyelitis. It's regular osteomyelitis of the long bones. Anything that's 4 to 6 weeks of therapy, and they still have. We've done a lot of one and done. So you have 1 week left, you get one, you get done. But we've done 2-dose pathways as well. We got 1-dose pathway and 2-dose pathway. And you need a line. That's the other thing. The complications of a line, and especially in these patients you're talking about, is obviated by this as well. So it's actually a very good phenomena. We haven't had an issue with allergy. Most of these patients, remember, these are vancomycin-like. They're all vancomycin ahead of time, so we've already tried them on that. So we haven't had an issue with allergy. I always had an issue with long-acting drugs because you had that tail effect. So as every drug, eventually you're going to go to zero. If you have a long half-life, that time between below the MICs of all these organisms and zero to be long enough to you worry that eventually you're going to get DRE or something like that. I don't know if that really, if it happens, it happens, but I haven't seen that issue occur clinically yet. My N is not that high, and I haven't seen it reported out there that much, but it's something that you have to be concerned about. Any drug that's long acting, there's a good and a bad sword of a long acting drug.
So it's only FDA approved skin and soft tissue infections, right? So,
True.
and I guess Dr. Cannell is saying that there are some studies that it's from Europe that you can use it for endocarditis. Do we have any studies as of yet that you know of for like osteomyelitis or this?
I do know that there was a DOT study that was done with that's part of the DOT study, but it's not for bacteremia, complicated bacteremia, and what was it for? And that just so that's there. And there's a lot of case series reported, but there's no. You're talking good studies. That one just closed. I do know they're still collecting data, but it's closed for enrollment.
We've been doing it.
Yes. So and it's been reported. This has been reported, like I said, a lot of places, but in a standardized fashion, like you're saying, no. There's studies ongoing now,
Right.
And finishing now. So our gram-negative agents I want to talk about briefly. Colistin, I'll just mention here. These are activities against resistant gram-negative bacteria. So we start getting the MDR gram-negative rods. These are the agents you start thinking about. All right. Some of the agents we'll have on formulary. Some of the agents we don't. And depending on where you practice, you might have differences in formulary of some of these gram-negatives. Tigasil is a glycocycline structurally similar to minocycline. So it's like minocycline plus. Indication actually skin and intra-abdominal infections, and early on when it was marketed out, a lot of people used it for intra-abdominal infections, and we weren't sure we were making people better or making them sicker with the GI side effects that people were having. It has pretty broad spectrum of activity, some gram-negative and positive coverage with some anaerobic coverage, including VRE, MRSA, strep pneumo. We also know it's becoming known as a mycobacterial potential drug because it has activity against several NTMs out there as well. The GI side effects is probably one of the rate limiting side effects. And we're mitigating that sometimes by using lower doses, and it's really a dose-dependent side effect profile, to be honest with you. I've seen it many times where you give the traditional dosing, pretty intolerable some people. Some people can breeze through it, believe it or not, but pretty intolerable some people. And if you can get away with lower doses, maybe for NTMs, actually is quite tolerable. And so I see it used in that arena more and more. Other quote unquote tetracyclines are ribociclib and omadacycline. Ribociclib is a little bit more potent than tigacycline. I've seen less of it used. It also has an intra-abdominal indication, but it has infusion site reactions that occur. I've not seen it used. Omadacycline I've used once, not for the SSTI or CAP indication again, but I've seen it used once for an NTM, I think it was at the time. It still has gram-positive, gram-negative coverage, but the cost of these agents are still pretty high as well relative to the other agents. But they're available, and sometimes you're stuck with the resistance issues, and you want to be able to use maybe an oral agent. I think Amana is oral, I believe. So those are the possibilities that could exist. We all know the ceftolozole and tazobactam. That's our Zerbaxa, and that Zerbaxa is a great pseudomonal agent. You need to think of Zerbaxa as a pseudomonal agent. You need ceftolozole and tazobactam, pseudomonas. Does it cover all this stuff? Absolutely. But where is it going to be in your toolbox? It's going to be in your pseudomonal toolbox. All right. It's increased activity against pseudomonas, including those that are overexpressing their AMP-C and overexpressing those effects pump resistant mutants. All right. It's actually indications. It's UTI, intra-abdominal infections when giving it with metronidazole. No one used it for that, even though the study was actually reasonable when you looked at it. Where we use it is when we have our NDR pseudomonases as our next agent in line before we can make it resistant to this agent as well, because I've seen resistance occur to this as well. Ceftazidime avibactam, that's our Avicaz, all right? So avibactam portion of this is a synthetic beta-lactamase inhibitor that inhibits the ESBLs, the AMP-Cs, KPCs, and OXA48 carbapenemases. So this avibactam is great. All right, think of it as a great agent that can attack these agents, but does not inhibit metal beta lactamases, NDM1 or VIM. Its main toolbox, it's in CRE infections. All right, this is where you're going to use it the most, but not in your NDM or VIM. If you use it together, ceftazidime avibactam and aztreonam, then you actually gain your NDM and your VIM ones, your metallobatic lactamases. All right. Meropenem vaborbactam or Vabomere. It's a vaborbactam is a cyclic chloronic acid beta lactamase inhibitor against class A and class C, mainly KPCs. So it's a good KPC agent for CRE. It does not inhibit the metallobatic lactamases, NDM or VIM, or any OXA enzymes as well. And just so you know, meropenem vaborbactam versus meropenem, there's no real enhancement in pseudomonal coverage, so you don't gain anything there. That's why when I see people say, well, why don't we look at Vabomere as a possibility for the pseudomonas? No. If you're resistant to meropenem, you're not going to gain anything there. There's imipenem and rilabactam. What's the brand name here? God, I forget the brand name. Just on formulary here. Oh well, I forgot the brand name. It's active against KPC carbapenems producers, including KPC2, avibactam resistant mutants. So occasionally you'll get the avibactam resistant mutants that occur, and this one could have activity against it. What?
Yeah.
Relstor is actually C. diff thing. No. It's an R, but I don't know what it is. Okay. Ricarbio. Thank you. All right. But this Ricarbio does not inhibit the metallobatic lactamases nor the oxas as well. So you have the problem there as well.
So it's similar to Avicaz and
similar to Avicaz, except for Avicaz has the oxas.
right.
Similar to the meropenem vaborbactam. Cephalosporins. All right. Hey, the last line of defense in my opinion. Gram negatives. All right. The cephalosporins. So it's actually a cephalosporin. So it's, I don't know, 6th generation. I don't know what they call it anymore. It's broad-spectrum. It's Enterobacterales, Pseudomonas, Acinetobacter, Stenotrophomonas. Poor anaerobic activity and poor gram-positive activity. So it's really good gram-negative activity. Has activity against the metallo-beta lactamases, so NDMs and VIMs of the world. Some resistant mutants noted, and mutations due to mutations in the iron uptake genes. The problem you have is the study that actually, had this help approval showed that actually there was a little bit higher mortality with its use compared to available therapy, best available therapy when the investigator chose best available therapy. It usually meant 2, 3, 4 drugs. And some populations of nosocomial pneumonia and bacteremia, and especially Acinetobacter infection. So while it has activity, mortality benefit in some of these individuals is not seen that well. And that's sort of this downside. But usually when you're reaching for cephalosporin, you got nothing else in your toolbox. That's the bottom of your toolbox. All right. So I'll show you in the last several slides. This slide sort of summarizes what your toolbox should be. For your MDR pseudomonases, you already lost your cephalosporins, your zosins, your quinolones, your meropenems. Your Baxter should be the top of your toolbox. If it's resistant to that, then you start having to say, is it cephalosporin an option? Using allergic acid, it's not, but you should check anyways. All right. For your KPCs, and actually you'll be seeing more and more where their series are identified of which type it is. With the genes. For your KPCs, if you know it's a KPC, you got three options, really. Usually your Avicaz, your cephazidin, your meropenem vaporactum, and your imipenem relebactam. And usually those are ones you would test for and see if they're available. If you happen to have an Oxa 48 carbapenems, remember you can't use your you can't use some of these other ones like meropenem vaporactum, imipenem relebactam. You got to use Avicaz, and if you're resistant there, you check the cephalosporin to see if that's an option. Once you have a metallobalactamase like an NDM1, you basically have two options. You have the combination of Avicaz and Astreonam or cephalosporin. I'm sure they're going to test you somehow with this, and this is pretty much a slide that kind of summarizes what you need to know as far as what agent you consider and what these targeted pathogens.
And for the beta-lactamase, the actual, so we don't care about the Avibactam, right? It's the ceftazidime or it's the.
No, it's the Avibactam and Astreonam. If they could get rid of the ceftazidime, you'd still be okay.
Right, but we don't have that drug.
There's no, not that I know of. All right.
Making a like Astreonam Avibactam combo.
They're looking at it somehow, and I forget how they're doing it. I don't know. The cost of these. Once you get to those combination drugs, they're not, ceftazidime is cheap. Tazobactam is cheap. Imipenem is cheap. Meropenem is cheap. Not when you combine them. That's what happens. You study them. You gotta recoup the costs. They're the cost of recouping. All right. It's not cheap at all. Omadacycline is not cheap as well. But, yeah, that's an oral version. That's what I've used it once before. I bring up one more slide, just a gee whiz type of slide. This is a drug. It's not FDA approved. It actually came to the FDA last year and it got denied. Tebipenem, scary drug. Why? Oral carbapenems. Oral carbapenem. Can you imagine this in the hands of hospitalists, family practitioners, APPs, UTIs?
India.
Actually, I think they have it in Japan as well. I think they have it in Japan. It's actually there's clinical trials, and I forget why they didn't get approved by the FDA. The FDA wanted more studies. I'm not sure where this drug is right now, or if it's or what the status is at this point in time. But it's not currently available in the U.S. But just so you know, there's one out there in the world being used. And then this drug that was actually approved this past May, sulbactam durlobactam. Basically, this is a drug that's going to be used for one pathogen, Acinetobacter. It's studied in HAP, VAP, and bacteremia caused by Acinetobacter complex, especially those carbapenem isolates in conjunction with imipenem. It was performed better than colistin. So I actually got an email from the drug rep this week. I haven't answered back yet. I'm trying to figure out how do you market this drug against one organism only. And this will be interesting to see how this plays out. That's recently got approved, FDA approved, and I guess it's going to start marketing because I got the drug rep emailing me about this. So summary, I'm sorry I went over. Actually, I went about an hour. Resistance increasing, very few agents available. Use your drugs wisely. And actually, also there's more diagnostics being available. You'll be able to tell what's a KPC, which one's an Oxa. You may be able to be able to target gram-negative easier. Utilize pharmacy as needed. They do all this pharmacy dosing, but they also a good resource to bounce ideas off of. I do that as well as you guys do that. All right. Think, evaluate properly before prescribing. Don't just do willy-nilly stuff. Don't be like the hospice who gets called for a fever and doesn't evaluate the patient, just starts something. It's easier to get that done. It's easier. I know we're all busy, but there was once a guy who I lectured, I can't remember where he's from. Every drug eventually has a targeted time period where your resistance occurs, depending on the amount of usage you have. Some of it's short, doesn't take much. Some takes a long time, but they each have a point where resistance does occur, because as we have this armamentarium against our bacteria, they have countermeasures, and they're always trying to find countermeasures to defend themselves. Thank you very much, guys.